A warm welcome to everyone. So I will be speaking today about addressing equity in health service in rural health services. And I want to start off by really underlying the importance of scaling up action for rural health equity in this moment in time. We are in a situation where extreme poverty is significantly higher in rural areas. Almost 4 in 5 people living in extreme poverty actually live in rural areas. Also, with regards to multidimensional poverty, most of the multidimensionally poor live in rural areas. Also, when it comes to the global inequalities realm, we see that the rural population comprises 67% of the population in low-income countries. So globally, we need to increase our focus on the rural poor, also to decrease inequities that are experienced between countries. When it comes to health, we know that in many countries and for many conditions, not all conditions, the rural poor typically have worse health. Just some examples. Stunting is higher in rural areas and in the poorest households. Under 5 mortality rate in many countries can also be higher. Non-communicable diseases, there can be greater challenges in accessing timely and appropriate services in rural areas. And when it comes to drinking water services and basic sanitation services, key determinants of health, rural areas typically fare much worse. The COVID-19 reality has shown us that rural areas are lagging behind and that they face many performance deficiencies when it comes to health systems readiness, preparedness for responding to a health emergency such as COVID-19. Some of these challenges that rural health systems are facing are inadequate numbers of appropriately trained health professionals, which will be discussed in depth today, poor facilities and infrastructure, including limited capacity in rural clinics to treat severe disease manifestation, shortages of key health products such as testing kits, PPE, and vaccines, weak referral systems and inadequate safe medical transportation, weak information systems and civil registration, and challenges to financial, geographic, and organizational accessibility of public goods and services. Also, we know that rural pockets with high community connectivity and crowding, combined with inadequate water and sanitation services, which then would influence and increase the risk of exposure, are particularly vulnerable. And this is also because these same communities often have much lesser access to quality health services. WHO has a survey called Pulse that looks at disruption to ongoing health services in the COVID-19 context. And it is showing that while the survey itself isn't disaggregating data, rural-urban, it does show that there has been a disproportionate impact on certain diseases that are typically more prevalent amongst the rural poor, such as neglected tropical diseases and malaria. So what would be, let's say, an overarching framework for responding to rural health inequities? In this slide, I want to show you that there's really 2 dimensions of such a framework. The first dimension would be strengthening rural health systems, systematically looking across the building blocks of health systems and seeing how each of these building blocks can better account for the needs of the rural poor. Then, in addition, we need to look at the cross-sectoral work that is required to address social and environmental determinants of health, engaging with other sectors such as employment, education, social protection, also engaging in sectors like for infrastructure, Watson, information communication technologies. In the context of climate change, we also need to engage with sectors that really safeguard our natural capital is to ensure a planetary health perspective. We need to look at inequalities within rural areas as well, and address those as key determinants of health. So that means looking at gender equality and looking at inequalities faced by ethnic minority groups, indigenous populations, migrants. And all of this is done in the umbrella of strong and stronger, I would say, multidimensional rural development policymaking that is backed by rural proofing across all of the different sectoral domains. Now, I have really 5 key messages for today. So in the context of building forward better for the rural poor, first we need to know who is being missed and why. Then we need to consider how we can really use primary healthcare oriented health system strengthening for moving forward and what that means for the rural poor. Then advance the agenda with regards to rural proofing. In addition, look at championing platforms for appropriate, meaningful participation of the rural poor and enhancing our approach to multisectoral rural development. These 5 key messages, I think, are critical for building forward better to take us to a new place when it comes to improve status of rural populations and reduced inequities. So I'm just going to start out with the item of improving rural health information systems. Of 673 household surveys in 133 countries, only 70% collected data disaggregated by urban-rural place of residency and only 58% by wealth. So in many country contexts, the rural poor are particularly, their realities are not being counted. So we need to improve household surveys, but we also need to improve the range of other information sources regarding the rural population. And so that also means civil registration. It also means facility-related data and other sources. But it's not only quantitative, it's also qualitative. And what you're seeing here in this slide is just a brief shot of some of findings from a barriers assessment that we collaborated with Site Savers and Countdown in Nigeria for regarding preventative chemotherapy for neglected tropical diseases. And the data that emerged from this study showed that there were specific barriers faced by herder populations, i.e. when the mass drug administration was happening, the herders were in another location. There were gender barriers as well. For example, if the male head of household was not home and the person distributing the drugs was a male, then the female at home would not be able to let the man enter and receive the drugs. There were also issues related to, motorcycle gas to reach rural remote areas, and then the drugs would also arrive too close to the rainy season, so not enable everyone to be reached before the rainy season made very distant remote areas inaccessible. These were all let's say, findings that came forth that the quantitative data alone would not have enabled us to really see. And we needed these findings to adapt and improve the preventive chemotherapy program to actually close the coverage gaps in these rural areas. So I just want to say, in addition to better quantitative data, it's better qualitative data and it's data triangulation. With regard to PHC-oriented health system strengthening, which WHO is really, let's say, promoting as a vehicle for resilience and building forward better. And when we do this, championing the needs of the rural populations is central. For example, operational levers. This is, you're seeing here the PHC framework. We have strategic and operational levers. With regard to certain operational levels like models of care, there are certain models of care that may be quite appropriate, let's say, to meet the needs of the rural poor, taking into account distance barriers. And also other demand side barriers that may be faced, including those that relate to finance, difficulties with accessing transport that's affordable, or the need to have accommodation also available for extended stays to visit higher levels of care. And then also with regards to things like medicines and other health products, ensuring they're accessible and affordable, in rural areas, or for example, digital technologies for health as an operational level, making sure that those are actually really considering the needs of rural populations and the rural poor in particular, and the providers that serve them, as those areas may have a lot less access to these technologies. And then just in terms of the primary healthcare oriented research, that is one that flags back to my previous point on strengthening health information systems, also with a qualitative lens for the rural poor. Rural proofing is a key message for today because I think it is centerfold in building forward better for the rural poor. So when we say rural proofing, we mean the systematic application of a rural lens across policies to ensure that they are adequately accounting for the needs, contexts, and opportunities of rural areas. Equity-oriented rural proofing means that we actually look at inequalities that can exist within rural areas, and that we ensure also that our policies in the health sector and in other sectoral domains are actually trying to overcome those inequalities. And rural proofing is appropriate for human resources for health workforce policies. And my colleague Michelle will talk more about WHO guidance that can be used as a tool for that. Participation of the rural poor. WHO has recently released this handbook, Voice Agency Empowerment Handbook for Social Participation for Universal Health Coverage, and it provides guidance on how to create equitable opportunities for participation, ensuring that all have a chance to have their voice heard, how to create sustainable platforms with adequate investment, and also it talks about the capacity building that's needed both of, let's say, policymakers, planners in the health sector, but also with communities to enable meaningful participation. And in rural areas, I think having the voice of the rural poor really centerfold in building forward better is paramount. And then finally, with regards to transformative multisectoral rural development, if we do this better, and if it's equity oriented, it will create an environment conducive to health system strengthening. It will address social and environmental determinants of health. It also can facilitate integrated people-centered approaches, for example, by linking social protection, better pension schemes, as well as long-term care opportunities and adequate health service coverage. It will enable a better people-centered approach. Also, it will strengthen rural governance and institutions. And so recently, we've been working with different UN agencies on this publication you see here on the left of the screen, tackling inequalities in public service coverage to build forward better for the rural poor. And one of the entities that we cooperate with is actually the UN peacekeeping branch. And they really stress the importance of strengthening rural governance across all sectors and rural institutions as a stabilizing peace maintaining force in countries, because in the vacuum of government power in rural areas and government provision of quality public service coverage, this lays the ground for, let's say, destabilizing terrorism forces also to come in, as we see in many countries globally. So the appropriateness and the importance of adequate multisectoral rural development and strong sectoral governance and strong institutions in rural areas is also a peacekeeping force. Then finally, socioeconomic multiplier effects of the health sector and other social sectors can be enhanced through appropriate multisectoral rural development. And then we also see that these types of strategies can really tackle some of the in rural area inequalities, and they can increase connectivity of rural areas with intermediary cities, which is particularly important for the continuum of care. And I just want to wrap up with this final slide showing ICT coverage in Ghana, Togo, Benin, and Nigeria along the Gulf of Guinea. And really it underlines that rural areas are a lot less covered with basic ICT and telecommunications, and that multisectoral planning is something that can help overcome this over time, and that would of course benefit the health sector and digital technologies for health. So with that, I'd like to close and thank you very much for having me with you today, and I look forward to hearing the other speakers.